Great. Thank you, everyone, for joining. I see there's lots of people still filtering in, but we'll make a start. As you know, we do this regular CVD update sessions from the DaRe2THINK trial team, and Alistair will give you a short review of that after the keynote speaker. And we're really grateful that Chris Gale is going to give us a talk today. So Chris is a friend and a great national treasure for cardiovascular disease, and has run huge amounts of really important clinical research, both here and abroad, from Leeds, Professor of Cardiology there. And thanks so much, Chris, for giving us this your insights into a really great program that you developed called Find AF. So I'll hand over to you, and yeah, really interested to hear what you're going to tell us all. Thanks.
Well, Deepak, first of all, thank you for the invitation, and more so, thank you for the introduction. It's always very humbling to hear those words. So yeah, I'm Professor of Cardiovascular Medicine and a consultant cardiologist at Leeds, and I'm going to talk to you about Find AF. I've got lots of slides and only a short space of time, so we're going to get you up to speed relatively quickly with atrial fibrillation burden and such like. So first thing is, using primary care data, we've clearly shown that among hundreds of thousands of patients of record, so that now there are more cases of a newly identified atrial fibrillation than the 4 most common cancers combined. So we've got a huge burden. We know it's driven by age, but we know it's on the increase, it's associated with multimorbidity, and it's here to stay. The problem with atrial fibrillation, as many of you are aware, is that it's associated with an increased risk of stroke. The solution to that is identifying patients and putting them onto oral anticoagulants. You all know that, and that anticoagulants reduce the risk of stroke by 2/3. The problem is that many cases of atrial fibrillation are just diagnosed too late when there's an endpoint, and that's not just stroke, but other things like heart failure, death, hospitalization, palpitations, and such like. Indeed, up to 15% of strokes will have AF as a new diagnosis. So there's a huge unmet need here. And I would argue that even though stroke is survivable and we can identify atrial fibrillation afterwards, it's a little bit too late, and we should be detecting it early in a proactive way. Now, the NHS long-term plan promotes early AF detection, although we're very much aware that the National Screening Committee does not recommend systematic screening across the UK. And that's in contrast to other guidelines, such as the ESC, that give different levels or classes of evidence as for the recommendation about the detection of atrial fibrillation. I'm not going to go into it in great detail, but there is a proposal for structured systematic or regional screening as a class 2A recommendation for people who have got CHADS-VA risk factors or are aged over 75 years. So there is an argument for undertaking screening. The problem with that is that when we undertake screening at a systematic level, the yield, that is the detection rate, is low, and therefore it's economically not viable or less viable. So we need to work out ways in which we can identify people or target people to be entered into a screening program or a case identification program. And that's been attempted in a number of studies. So Stroke Stop have done that, and actually the Stroke Stop BMP study found a really nice yield of 7.4%, and that's in comparison to many of the other studies that have yields about 2 or 3%. So we thought we would bring some brains together and try and solve that problem, because in the UK, as you are aware, 98% of the population have got an NHS health record and therefore are amenable to detection of disease through their health records if we could predict that. And so we wanted to design an algorithm that could be inserted into the NHS health records, primary care records, to identify people or predict who's at risk of having atrial fibrillation yet undiagnosed. And that speaks to digital prevention, neighbourhood care, so those policy recommendations that are currently active. First of all, we did a literature review to find out what was happening out there in terms of people developing risk models. And we found that actually many of the risk models, although they were published, had substantial weaknesses. And we wanted to overcome those weaknesses. And that's why we did a review of the literature to find out where the weaknesses were. One of them was long prediction horizons. So algorithms that would predict whether you were going to get atrial fibrillation in 10 years' time, which I would argue is irrelevant. And we therefore designed a model that could predict atrial fibrillation at a much earlier horizon, but also trying to be more powerful and to increase the prediction yield. We also did a big review of the literature to find out actually the detection rates of these prediction algorithms. And it's very interesting that in prospective cohorts, observational cohorts, on average, the diagnostic yield for atrial fibrillation when you do apply a prediction algorithm is just under 3%, 2.75%. And if you look at trials, the pooled relative risk of intervening upon in terms of detection versus control arm of detecting atrial fibrillation is about a twofold increase. So those are important numbers to remember compared with what we generate later. We brought together lots of different stakeholders and partners because we wanted this to be large scale and well informed, but also implementable. And you can see there that we had a scientific advisory board, lots of primary care partners and input, and as well as national and regional stakeholders, including funders and such like. We developed a model using the CPRD data bank. So that's the primary care data bank, or one of them that's linked to HES records. And we looked at about 2 million people with and without atrial fibrillation. And we used a random forest classifier, a type of AI, a relatively straightforward AI algorithm to generate predictions. And what we wanted to do is use the variables that were routinely collected in your health records. So nothing fancy, nothing like did you do an ECG, or even what did the ECG show, or nothing like a biomarker or an imaging thing. It was really straightforward parameters such as age, sex, ethnicity, and some diagnostic codes that you all collect for your patients. What did the model look like? Well, here's some of the output statistics, and these are numbers that show that the model performance, that's the maths behind the model in terms of its prediction, were actually quite good. So the area under the curve was 0.8, we had a Bria score that was reasonable, and in fact we found that people who were predicted to be high risk compared with those who were predicted to be low risk at a horizon of 6 months prediction horizon were 20-fold higher or 20-fold likely to have atrial fibrillation. It had a negative predictive value of 99%. That means if you were scored low on the Find AF algorithm, it was very unlikely that you'd get atrial fibrillation. But the downside was the algorithm used 72 predictor variables. And I said to the team, that's far too many. We need to reduce those. So we reduced the variables down to about 12. We did that through international stakeholder involvement and feedback, as well as model parameters. We then ran that model not only in the UK, but across the world, now in about 13 million people across the world, to show that the prediction performance was upheld in that newer, smaller AI algorithm. So what? Well, it worked in the different geographies. Only one country didn't work quite as well in terms of its enhanced performance, and that was in Israel, probably because of different demographics. The characteristics of the patients who had AF and who had higher predicted AF but didn't have AF were very similar, suggesting that people with high predicted AF are about to get AF. And then we popped some patients through a cardiac MRI scanner, so a fancy scanner that takes really in-depth pictures of the heart, and we focused on the left atrium. And we found that when we compared people who didn't have AF but had a high Find AF risk score, they were more likely to have scarred or fibrosed atria. Those are the top pumping chambers of the heart. And what we found in people with atrial fibrillation is they not only had the scar, but they also had atrial failure. That is, the ejection fraction and the size of the atria was low and high, respectively. But interestingly, people with pre-AF, so a high FIND-AF risk score, were having scarring of the heart, but the functional aspect of the atrium was maintained. Again, so what? Well, we needed to test this prospectively, and that's where the FIND-AF algorithm and clinical pathway came in. I wanted a remote pathway that didn't involve additional burden for hospitals, GPs, or nurses. And so we generated a long list of people with FIND-AF scores in primary care. We partitioned those into high risk and low risk. We sent them automatically, just as you and I get a text to go and see your GP. We sent them an automatic text to say, do you want to be part of this study? If so, we'll post out a consent form and an information sheet, and if you sign that, we will then send you a remote heart monitor, which we did, and those heart monitors were used intermittently over 3 weeks, where people would put their fingers on this little device for 30 seconds, 2 or 3 times a day, to see what their heart rhythm was. And then we'd automatically diagnose them with atrial fibrillation, no atrial fibrillation, or something else, and write a letter to the GP and to the patient to inform them. What's important here is that we pre-selected patients who are high risk for stroke. So they already had a CHA2DS2-VASc score of 2 and 3, males and females, and no contraindications to oral anticoagulation. So as soon as we detected atrial fibrillation, used one of these Xenicord diagnostic devices, then we could automatically say to the general practitioner, hey, this patient needs a little bit of counselling about an oral anticoagulant. If there are no contraindications, please prescribe to reduce their risk of stroke. And that's in line with current guidelines. So we'd sent out about 17,000 invitations. That sounds an awful lot, but once it's automated, it's actually not too bad. And we identified 1,923 participants, and they were from all areas around Leeds. And as you know, digital or data doesn't discriminate in terms of sex, age, ethnicity, or social deprivation. So we could reach into everyone. The question is whether they actually participated or not. This is the baseline characteristics. I'm not going to go into detail, but there are differences as expected if you are low risk versus high risk of having atrial fibrillation. What are the main results? This is the efficacy primary outcome of the diagnostic yield of atrial fibrillation. If you were predicted to be high risk with FIND-AF and went through the program, the detection rate or yield would be 4.5%. which is nearly double that of previous reports, and the odds ratio between low and high was nearly 9-fold difference. So if you were low risk, you were unlikely to have atrial fibrillation. What's also very interesting is at first use of the heart rate monitor, we detected lots of atrial fibrillation, suggesting that people have undetected non-screened atrial fibrillation and are sitting there in the community with it, waiting for an endpoint event. This is the sensitivity positive predictive value and negative predictive value. So sensitivity was high at 90% with a negative predictive value of 99, which is very good for screening interventions there. Secondary outcomes, in fact, 97% or so of people who were detected with atrial fibrillation went on to receive anticoagulation. We found 2 cases of safety endpoints, one with a heart block and one with a broad complex tachycardia. The number needed to participate in the screening or detection program was 26, and the yield on the first ECG was nearly 50%. So it seems that lots of people out there with atrial fibrillation that have just not been detected. It's now a UK certified medical device, so it's been regulated as such and can be used out with research. And we had lots of news media stories about it about a year ago when this emerged. and we've had excellent patient feedback, and this is really quite moving. And when we've presented this to our stakeholders, this chap here, and he doesn't mind me mentioning him, John Pagali, he really gives a fantastic story of how he was part of this project, was otherwise, inverted commas, well, had a Xenocor device because he was and was predicted high risk, and then was informed he has atrial fibrillation, and takes a pill now to thin his blood and reduce the risk of stroke, and feels more confident with life. What are the limitations? Well, we found from the research study that the consent rate was relatively low. I'm not too worried about that, because we can use digital means to reach out to lots of people, and we can continue, if necessary, and if this was been placed into the NHS, continue to identify these people and notify them for detection devices. Of course, the threshold for the screening may vary between different countries, as we showed in one of our studies, and we of course didn't randomize this study nor test it for effect on stroke, and we can discuss that later. So behind the scenes, lots of work. We delivered this through the operational part of this through one of our hubs in Leeds. This is Seacroft Hospital, where's the nerve centre, or the nervous centre, and this is where the work happened in collaboration with university people as well, but this is the delivery part of it. But actually, it was all remote and digital and out in the community. And of course, thanks to the NIHR for supporting this, and the British Heart Foundation. So in conclusion, FIND-AF is a parsimonious model. It's been tested and validated internally, externally, and pilot implemented under a consented study. It's now ready for use in the NHS. It's a certified device, and it can be applied at scale. And this is just a shout out to all my colleagues, both locally, regionally, nationally, and internationally, who have helped do this. And without them, I certainly wouldn't have been able to do any of this. And of course, the funders, including British Heart Foundation, NIHR, and Leeds Hospital Charities, amongst others. And I'm going to leave it there and end my show, and then wait for questions and answers, if that's okay.
That's fantastic. Thanks, Chris. Amazing work. Congratulations to you and your team for all of that stuff. We've got a few minutes for questions, so if you have any, you can put them in either the Q&A or the chat, whichever's working on your side. Whilst we're just waiting for some questions, I guess just as this, obviously these sorts of things are being deployed within NHS care, what can our kind of practitioners kind of do at the moment? Because a lot of people are coming to them either with their own Xenocor or some other devices, right? So do you have some kind of suggestions at the moment how to deal with that? Because there's a lot of confusion out there about how good devices are and what we should use in clinical practice.
Yeah, really important question, because there are two aspects here. What's a diagnostic and certified device, and what's a detection device? And there are some devices, technologies that are diagnostic, and we can name them. You can look on the NICE website for those as well. And we clearly chose one that had been used in research and is known to be a diagnostic device. There are other ones. There's the iRhythm Zeo patch that's on the NICE website as well. And those are two different things. So one is an intermittent monitor where you put your thumbs on every now and again, and that will potentially characterize a very different type of heart rhythm to a continuous monitor, such as a patch that you have on all the time. It'll pick up all your heartbeats, and therein lies the debate as to what is AF and how much AF is AF, and therefore what's the burden of AF that we should start anticoagulation. And Deepak, you're much cleverer than me and can answer those questions, but my feeling is that's still in a research area. But I tend to think of it as, well, what's your risk of stroke, and how does that counterbalance the burden of atrial fibrillation or not, as a reciprocal relationship. The other point of your question was, what does it actually mean when a patient comes to you with their Apple Watch or their Garmin watch? I interpret those and I say to the patient, they're digital symptoms. instead of you expressing your symptom of palpitation, your watch or your device has expressed that as a digital symptom. And therein lies a difficult question as to whether we can say that Apple Watch was actually a diagnostic device or not. I tend to say it isn't, and I don't think it's regulated as a diagnostic device, but the algorithms behind the scenes on that are actually quite sophisticated. But I tend to try and get a diagnostic device. The issue is if they've got paroxysmal atrial fibrillation and we get these little squiggles or even just high blips of heart rates on a watch, and then you don't capture it on a 24-hour tape or an ECG. That's either because you haven't done enough monitoring or they don't have atrial fibrillation. But we should certainly take it seriously, these digital symptoms.
No, that's really important. I think the point you made at the beginning was basically around clinical versus kind of subclinical device detected AF. And I think that's obviously going to become even more important now we have more and more devices. Certainly in the guidelines, the European guidelines that we wrote, we kind of strategize really around the fact that often, as you said, it's the underlying risk of stroke and blood clots, dementia, so on, that's often going to determine your management. So, and that's regardless of whether you've got clinical or subclinical AF, and is really, the factors there that are really important, the comorbidities that you have, and adequate treatment that is usually not done very well for these patients of all of their underlying comorbidities. I think you've answered Daniel's question about Xenocor, so I'll move on to Kate, if you just quickly tell us what was the cardiology process for reviewing the ECGs and diagnosing AF?
Oh yeah, no, it's a great question. And again, we didn't want to burden our general practitioners and people in the community with additional work, so we took on that work. But actually, Xenocor there's an algorithm that can look for atrial fibrillation, but we went through all of the telemetry, and there are lots of them to go through to detect atrial fibrillation. Certainly, where there was where we were uncertain, we would get at least one, if not two EP people, and then arbitration after that to determine whether it was in fact atrial fibrillation or something else. So we spent, because it was a research project, we spent a little bit of time and investment in that area. But one would hope that if you use a diagnostic device that's certified, that'll give you the report. But you definitely need some sort of clinical oversight of that report.
Yep. Okay, no, that's great. So thank you so much, Chris. I mean, if there are any other questions, just pop them in the chat, and we'll get Chris to have a look at them and respond back to you guys, and we'll get back to you individually. If you have time, we'll just move on to Alistair. Is Alistair?
Sorry, Deepak.
Great.
Esther you had your hand up. I don't know if you'd like to ask a question.
Oh, great. Sorry,
yes,
I
just had one question. Thank you very much, Chris, for the presentation today. So you showed a slide on left ventricular features and the associations with atrial fibrillation. I'm just wondering, there has been increasing interest in also the role of the right heart in atrial fibrillation. Did you run any analyses on some right heart features as well?
We didn't. It's a fantastic question, but we are doing that because the BHF have supported us to do what we call a phenotyping project in the high risk category. So that is going on at the moment, but well done you.
Thank you for that. Thank you.
Great stuff. Great. Thank you so much, Chris. Amazing as always. Alistair, we'll hand over to you for the last 5 minutes.
Great. Thank you very much. I'm just going to take just the last 5 minutes just to discuss the DaRe2THINK trial, who are the hosts of this webinar. Sorry, I'm just going to quickly share my slides. Great. So the DaRe2THINK trial is a National Institute for Health and Social Care research funded collaboration between the University of Birmingham and Clinical Practice Research Data Link. The project is looking to use routinely collected primary care data to integrate clinical research into the usual care, reducing the burden for both NHS staff and patients. The DaRe2THINK trial is an exemplar of this new delivery method and targets a key public health issue of how to prevent cognitive decline and vascular dementia in patients with the heart rhythm disorder atrial fibrillation. The trial can screen from over 13 million NHS records to identify potentially eligible patients. The trial now has over 500 GP practices actively screening and recruiting patients, and we continue to look to open new practices. Previously, this was limited to EMIS web practices, but now we're looking actually to announce a pilot of System 1 practices in mid 2026. We are continuing to recruit patients and have had a great uptake with into the trial, with over 1,200 patients now recruited, and that is a 20% uptake of all of those patients that have been invited to take part by their GP, showing the key public health question that we're asking. Patients can take part in this study completely remotely, enabling patients to take part without leaving their home and reducing the burden on NHS staff. As I mentioned, we are continually looking to recruit practice to the study. If you're on this webinar and aren't yet taking part, or not sure if you're taking part in the DaRe2THINK trial, then scan that QR code and we'll be able to recruit. We'll have a quick conversation and potentially recruit your practice to the study. Any DaRe2THINK practices that are currently taking part, that are looking to just be reminded on exactly what activity you have left to do for the study, then scan that QR code and we're happy to meet and talk you through the next steps in taking part in the trial. That is it from me, but thank you very much for joining us today, and we look forward to seeing you on our next webinar, which will be hosted in a few months' time. Thank you very much.